Hi, my name is Catherine Sharrett. I'm a registrar in infectious diseases and general medicine at Addenbrooke's Hospital, Cambridge. This is one of a number of COVID-19 related talks written in early January 2021. This is going to be a brief discussion of conditions that have commonly caused concern or been associated with COVID-19 inpatients in CUH during the last year. It's not intended to replace good clinical assessment. It's not going to be a comprehensive and exhaustive guide to management of these conditions, just a primer or heads up to remain aware that a diagnosis of COVID-19 is not the end of the story. For any clinician out there who thinks there's something been missed, please do tell me, and we'll update it for the next set of these talks. Firstly, cardiac failure. Different aspects of cardiac failure in COVID-19. Firstly, there can be diagnostic uncertainty. Secondly, the temptation to enthusiastically fluid resuscitate patients with fever and tachycardia. And thirdly, over-diuresing patients where viral infection is the underlying problem and not fluid overload. In a patient with a history of cardiac failure and COVID-19, it can be difficult to distinguish the driver behind a patient's deterioration. Fever and lymphopenia driving towards the diagnosis of COVID-19, clinical features of overload, peripheral edema and raised JVP would drive towards a diagnosis of fluid overload. Previously known weight or dry weight, sometimes available, if you search for heart failure notes, can be helpful. Chest x-rays can be difficult to call one way or the other, although fluid in the fissures and the costophrenic angles will be more indicative of cardiac failure. Either way, in either condition, fluid balance and monitoring fluid balance is critical. Document fluid prescriptions carefully. Check what others have prescribed and delivered before you, and review regularly the patient's fluid status, documenting urine output. When monitoring diuretics, when modifying diuretics, monitor renal function with daily blood tests. In times where changeover of teams is common, clearly document what you were thinking at the time when you made changes and plan to allow others to pick up where you've left off. Viral-induced exacerbation of pre-existing airways disease is common. It's not abnormal that COVID-19 can cause this. Management is for viral exacerbation with oxygen, steroids, salbutamol, ipratropium, magnesium, and so on. Where there's evidence of previous carbon dioxide retention, consider prescription of oxygen to maintain saturations of 88 to 92%. When hypoxia is present, give oxygen and reassess. Hypoxia will kill faster than hypercapnia. Perform arterial blood gas sampling and react to changes. If acidosis develops and type 2 respiratory failure, ask for help with ventilatory management from the respiratory or the rapid response teams. Act on their advice whilst awaiting review. They may not be able to attend immediately. For patients with pre-existing airways disease, recovery from COVID-19 can be a longer process, with oxygen saturations remaining low for days and weeks. For some patients, awake proning, lying on their front, can be helpful in managing symptoms. For others, discharging home with oxygen may be necessary. Please see the discharge talk for further information. Most of the respiratory symptoms of COVID-19 can be attributed to the viral infection and sequelae. However, some patients will go on to develop bacterial superinfection. Within the group of patients who have been admitted and remain in hospital, hospital-acquired infection can be suggested by a new productive cough, recurrence of fever that had previously settled, increasing oxygen requirement, new crackles on auscultation, or suggestive features on a chest x-ray. It can be difficult to distinguish bacterial superinfection from the normal process of COVID-19, given high fevers, raised CRP, increasing oxygen requirement, and a cough are frequently a feature of the latter. Where antibiotics are indicated, these should be initiated as per the hospital guidelines. There is also another talk about this. Consider whether aspiration is potentially a cause for the HAP and request a review from the speech and language team if that's the case. Symptomatic postural hypotension in patients with no previous medical conditions has been seen remarkably frequently on the wards. This appears for the majority to be self-limiting. Where we've performed investigations, these have come back very normal, but can be quite disabling with dizziness and pre-syncope. Advice about slowly moving from a sitting to a standing position, whilst apparently obvious, is pretty useful. There's another talk about VTE prophylaxis, but enough to mention here the high rates of pulmonary embolism, large and small, that we've seen. Ensure that VTE prophylaxis is prescribed for all patients presenting with COVID-19. If there is deterioration in clinical condition, with increasing shortness of breath, falling oxygen saturation, perhaps only present when mobilising, have a low threshold suspicion for a clot. Perform arterial blood gas sampling. Request further imaging, but don't wait for imaging to treat if you've got a high level of concern. Chest pain in a patient with COVID-19 may be cause for suspicion of PE, but should also raise the possibility of acute coronary syndrome. Repeat ECGs and serial troponin will help. COVID-19 is not a contraindication to the management of a myocardial infarction, and inviting the cardiologists will be helpful. Use of dexamethasone at 6 milligrams once a day for management of COVID-19 has frequently been resulting in raised blood sugars, which mainly settle after the cessation of treatment. For any patient prescribed dexamethasone, check the blood sugar in the morning and the evening. Where these are raised, discuss with the diabetes team and consider the introduction of anti-hyperglycemic agents. For patients who are being stepped down from ICU, please consider the fact that they will have been given dexamethasone and quite often parenteral nutrition and have been given anti-hyperglycemic agents. For anyone where we are decreasing the amount of steroids or decreasing the provoking agent for them to have hyperglycemia, ensure that we are decreasing the anti-hyperglycemic agents at the same time and regularly reviewing these. The final condition that I'm going to mention is delirium. Management of delirium ideally involves correcting the correctable and nursing in a calm and reassuring environment. Whilst treatment of COVID-19 itself is limited to the use of oxygen, steroids, and in some cases remdesivir and tocilizumab, the treatment of other correctable causes of delirium is not as limited. Has the patient been prescribed their regular medications? And if not, can they be? Are they in pain? And has this been inadequately controlled? Do they need all of the medications that they are prescribed? Decreasing pill burden not only avoids the side effects of these medications, but allows nursing staff to focus on getting the most vital medications to be complied with by patients. Do they have a disturbance in their metabolism? Are they eating and drinking? Are their electrolytes correct? And can they be corrected? How about their thyroid function? How about their blood sugar? Do they have a neurological problem? Is there a CNS lesion? It can be possible to have had a stroke. Do they have a difficulty with their vision or their hearing? Do they normally wear glasses? Do they normally wear a hearing aid? Can this be mitigated? Can we get hold of those items? It can be very disoriented to be in hospital for a lot of people. And it can be very disorientating to be nursed by people whose faces you can't see. And where there's an acute injury to the person's mind, such as delirium, this can be even more so. Be sympathetic to this and try, where possible, to reassure patients. If family members or care home members can bring items that would be helpful, this could be anything from a photo to a teddy to a doll, encourage them to do so. PALS can arrange for these to be brought to the ward. Dress patients in their own clothes. Minimise unnecessary medical interventions. Where elderly care nurses have been redeployed to the ward, seek their advice and assistance, because they can be absolutely invaluable, having spent many years of looking after patients with delirium. I've put a slide in here with some useful bits of information, all freely available on the internet. The COVID-19 at CUH document written by Claire Leong is a great document summarising what we know about COVID-19 and how it's being managed at CUH. In-depth antibiotic guidelines are available, but most helpfully, the antimicrobial app is available on the front page of the hospital intranet. VTE prophylaxis, discussed in depth by Dr. Sunny Koscioni in another video, is detailed in the document library. The document that may be particularly helpful for those redeployed to unfamiliar wards with unfamiliar teams is the CUH Emergency Handbook written by Dr. Ali Mackett, amongst others. This has a surviving on a medical ward hints and tips section, which is great. I've also put here the induction app, which if you don't have it yet, is pretty helpful. You can find it through the App Store or other services, but it has a lot of contact details for patients, for medical and nursing staff within the hospital. Also on intranet is Rota Watch. There's always help and advice available. I've put down some people here. Don't feel offended if you're not there. But there's 24-hour support from all of these teams. That's it for now. If you've got any feedback about this talk, please feel free to email me at my Adam Brooks email account. Thanks. Bye.